Evening, everyone. I welcome you all. I thanks to all the faculty and delegates for joining today Sunday evening. This is our third part of the look back at 2020. And the first part we have discussed the breast cancer on 33rd December. And yesterday we have a good academic feast on the pancreatic cancer. And today we are going to discuss about the advanced head and neck cancer. So for the today's agenda, we'll start with our first lecture on the immunotherapy, and followed by we have a two great debate. The first debate would be on first-line treatment in advanced and recurrent head and neck cancer, and debater for the immunotherapy, Dr. Vamshi Krishna. He is a senior medical oncologist practicing at Hyderabad. And for debater for our non-immunotherapy in favor of TP Extreme, Dr. Bharat Vaswani. He's also a senior medical oncologist practicing at Yashoda Hospital, Hyderabad. Great debate two, we have in the second line treatment on the same advanced and recurrent head and neck cancer. And debater for immunotherapy, Dr. Shruti Kate, she's from HCG Cancer Center, Nasik. And debater for Metronomic Chemotherapy is by Dr. Pinaki Mohto. He's a medical oncologist practicing at HCG Cancer Center, Baroda. And followed by, we have a case-based panel discussion by Professor Dr. Govind Babu sir. And with this, I think I'm going to start with my first lecture, and that will be on immunotherapy, optimizing treatment for recurrent and metastatic squamous cell carcinoma with immune checkpoint inhibitors. So we all know the head and neck cancer is cause a lot of morbidity and mortality to our patients, and this cancer is responsible for major functional and social and psychological impact on the patient's outcomes, especially the treatment-induced toxicities, especially with the radiation, chemotherapy, as well as with the surgical morbidity. So all comes in very important way when we treat this kind of the patient. We all know, and our patients, majority of the patient in our cancer are diagnosed in the advanced stage. So our role is addressing in the unmet need for the patient care, especially in the multidisciplinary team approach. And we need to treat the patient in a multidisciplinary clinic because most of the patients require a multimodality treatment. And I think for optimal patient care, this is very important. So we all know the MDT approach is optimal for the treatment care, all malignancies, especially with head and neck cancers, because head and neck cancer requires a lot of morbidity surgeries also, and especially in our patients which are diagnosed at advanced stage. So this multidisciplinary team approach involves head and neck surgeons, radiation oncologists, medical oncologists, plastic surgeons, nursing care, dental care, as well as the speech and swallowing therapist, nutritionist, pathological and neurological departments. All are play a very important role in the optimal patient care. If you see the incidence of head and neck cancer in our country, approximately 20% patients are diagnosed in head and neck cancer, assuming a total incidence of our country approximately is around 12 lakhs per annum. So we have around 2.5 lakhs of new TB cases every year with advanced head and neck cancers. In spite of all the treatment options, we all know the majority of the patients are relapsed, and approximately 50% patients are relapsed within 2 years. Even with a stage 1 patient, 30 to 40% patients are relapsed. And so that's the main reason we are discussing, because those patients, even the relapse, they require a subsequent line of the treatment, and probably they helps in the further benefit to the patient. Probably they are helpful in the survival of the patient, good quality of life, and optimal outcome. We all know platinum-based therapy is a major role in the management of advanced head and neck cancer. And single-agent platinum is one of the most common regimen, whether it is given as a combination with the radiation with the locally advanced head and neck cancer, or even in the patient with the adjuvant setting, where the patient has been underwent local treatment like surgery, followed by the patient require radiation. So single-agent platinum would be one of the standard care. But if we consider those patients who progress after the exposure of the platinum, I think the outcome of this recurrent and metastatic head and neck cancer is very poor, especially if they progress with the platinum, and very limited options are there. So we all know head and neck cancer is an immunosuppressive tumor, and a lot of immunomodulations occur at the multiple levels in the squamous cell carcinoma head and neck microenvironment. And one of the major pathways is the T cell suppression, and that's probably one of the major factors which we can target. Coming to the T-cell activation therapy, one of the important drug is the Novolumen, which is a fully human IgG4 PD-L1 receptor monoclonal antibody, and which inhibit the immunosuppressive mechanism, which is directly involved in the tumor site. And I think with this involvement of PD-L1 pathway, I think this binding leads to reactivation of the T cells and they restore the normal T cell functioning. One of the major landmark study for Novolumen, we have a CheckMate 141 study, and we have a 2-year update is also there now, which is the outcome of Novolumen in advanced and recurrent squamous cell carcinoma of head and neck cancer. So coming to the study design, so this is the design of the study. So CheckMate 141 study is an open label phase 3 trial with the recurrent or metastatic head and neck cancer who had progressed either on the treatment or within 6 months after exposing the platinum-based therapy. So this is the major eligibility criteria. The patient of all head and neck region could be oral cavity, oropharynx, larynx, which are actually non-amenable to curative treatment. And these are the patients either to progress on the systemic treatment after receiving the platinum or within 6 months of the last treatment. These are the patient with a good performance of ECOG 0 or 1, and regardless of the PD-L1 status, the patient is randomized on 2:1 ratio of Novolumen 3 mg per kg body weight every 2 weeks versus the treatment option as per the investigator choice. That could be a methotrexate, Metronomic Chemotherapy, docetaxel, or Cytokine. The primary endpoint for the study was overall survival, and the other points were PFS, overall response rate, safety, and other quality of life criteria. So this was the patient demographic. We see the patient demography on the basis of age, sex, whether history of smoking or ECOG performance status or tumor site or the treatment received. I think it's optimally balanced in both the arms. Coming to the data capture for the subgroup analysis, I think quality of the data is one of the major concern, but other things would be the prior use of the cetuximab, the age-wise distribution, Hpv status, whether these patients are the Asian or non-Asian. So all the criteria has been considered for this study for the subgroup analysis. So coming to the outcome, I think in this study, the overall survival is in favor of Novolumen. If you see, the median OS is 7.7 versus 5.1 month, and HR is 0.68. If you see the 2-year data of Novolumen is approximately 16.9% patients are survived in 2 years versus 6% patient of the investigator choice. So that I think leads to 32% reduction of the risk of death at 2 years compared to the investigator choice. So that's favoring the Novolumen. We see the benefit of immunotherapy is more coupled with the durable response, and this overall survival benefit is observed at 2 years. Around 1 every 6 patient is been live compared to the 1 in 16 patient in the investigator choice. And beside that, the over duration of this is also double in favor of the Novolumen, though the median time to response was similar in both the arms. If you see the data on the basis of PD-L1 status, I think both the category, whether the PD-L1 is low, less than 1%, or even 1% or more, the both category of the patients are benefit with the Novolumen compared to the investigator choice, though the magnitude of benefit a little more in the patient with PD-L1 is high. So what are the patient population in this CheckMate 141 study? So these are the patients who are either a localized state patient, they initially treated with the induction regimen and they have a disease progression, or the patient who is treated with the chemoradiation and they have been disease progression within 6 months, or those patients who receive the adjuvant chemoradiation and they have a progression of the disease within 6 months. So the and second category of the patient are those who are recurrent metastatic patients. So these are the patients which have been included in this study. And one of the major criteria which was observed in the study, so those patients who's been exposed immunotherapy, especially Novolumen, earlier, they have a more magnitude of the benefit. So the outcome were analyzed in the post-hoc in the patient who are platinum refractory in the primary or adjuvant setting. And these are the patients who received Novolumen versus investigator choice. I think in those patients, around 21% patient, they received the first line Novolumen after exposing the platinum in this primary and adjuvant setting. And if you see the 2-year outcome, and these are the patients where the early use of Novolumen, they have around 21.6% 2-year overall survival compared to the 3.8%. So this magnitude is around 5 times higher compared to the investigator choice. So that is one of the major population where this gives the highest benefit. Coming to the response rate, this nivolumab leads to the approximately 20% response compared to the 11.5% of investigator trial therapy. It's great. And one of the important thing which we always look for head and neck cancer patient is the quality of life issues, because our combination treatment is more toxic. So single agent nivolumab is maintaining the patient quality of life, whether it is a physical or social functioning, patient's symptoms control on the basis of like fatigue, dyspnea, appetite loss, all are in favor of immunotherapy, whether it is a pain sensitive problem or social issues. So there is one of the subgroup analysis for those kind of the patient who achieve a response. So those patients who achieve the response, whether it is a CR or PR, they have a more magnitude of the benefit. So the median OS is still not achieved. And if you see the 18-month survival rate for those patients who achieve either CR or PR, the survival rate is 18 months is 86% compared to the 31%. So this is a great benefit for those patients who are responding. So those patients having a stable disease, even those category of the patient also benefit. The median OS for the patient having the stable disease is 10.4 versus 7.1 months. So 18 months survival rate is 32 versus 11%, favoring the nivolumab. The data on the basis of cetuximab, use of cetuximab doesn't compromise the outcome, but the patient who is without exposed to cetuximab, they have a more greater benefit. And if we see the benefit on the basis of the age, I think whether the patient age is less than 65 or more than 65, all the category of the patients having the equal response. Even the HPV positive or negative doesn't going to change the response. So nivolumab is beneficial over investigator choice in both the subset. Even the Asian population compared to the intent to treat population, the median OS is almost the same, 7.7 versus 7.7 months, favoring the immunotherapy arm. So this is one of the table which shows the subgroup benefit. I think all the subgroup, whether it's irrespective of the age, ECOG performance status, prior use of cetuximab, prior treatment, even the site and the prior line of systemic therapy, all the arms are favoring the benefit of the immunotherapy, especially in the nivolumab. Coming to the safety profile, at 2 years, around 4.2% patient is discontinued compared to the 9% related to the adverse event, so favoring the nivolumab. And even if you look for the grade 3/4 toxicity, which is almost less than 50% over investigator choice, around 15 versus 37%, that's favor the nivolumab. If you see the common side effects, I think the nivolumab is easily well tolerated, except for some of the patients having immune side effects. So one of the important things when to investigate this patient for the response, I think one of the major suggestions to look for the primary assessment at 9 weeks. And after that, we need to go for the subsequent assessment at 6 weeks. So if the patient those are responder, I think these are the patient is the highest, I would say, responding category. And I think 80 to 85% patient is going to maintain the response at around 1 to 1.5 years. And this treatment should be continued till the patient has I think there is an intolerance or if there is any disease progression. So what I can conclude, so head and neck cancer have a major social, physiological and psychological impact. MDT should be one of the major concern for this kind of the patient, and that look for the optimal patient solution. There are the survival benefit of nivolumab in a patient which initially treated with recurrent head and neck cancers. And the platinum-based patient having a higher magnitude, particularly in the patient who are received earlier nivolumab, they have a 5 times of the benefit of nivolumab versus investigator choice. That is around 21.6% versus 3.8. The quality of life is much better for this category of the patient over the investigator choice. And even the Asian subgroup, which is one of the major area of concern, this nivolumab shows around 60% reduction in the risk of the death compared to the investigator choice trial. So I think with this data, I think we can say immunotherapy is one of the preferred modality compared to the investigator if there is a cost is not a concern. Thank you. Thanks for warm listening. And I think we can now move to our next session. I'm not getting any question in my chat. So I go for our first debate. I think the first debate is the first line treatment for recurrent and metastatic head and neck cancer. I invite Dr. Vamshi Krishna and for immunotherapy.
Good evening, Dr. Ashish. Thank you for inviting me. I request the organizers to please share my slides. Thank you and good evening. As said, I have been asked to speak on from what is the new king and the royalty in head and neck squamous cell carcinoma, and that is immunotherapy. Next slide, please. We all read this phrase in our forensics that res ipsa loquitur, and the thing speaks for itself. For me, this debate is actually kind of pointless. I'm really not sure why we are doing this because the thing really speaks for itself. Next slide. We had two major papers. Now, just look at what we are debating. We are debating pembrolizumab alone or with chemotherapy versus cetuximab with chemotherapy, Keynote 048, a randomized open label phase 3 study. Now, all of us learned in statistics that the best evidence for anything would be probably a IPD of meta-analysis, but barring that, the next best and something we all follow is a randomized open label phase 3 study. And this study, if Dr. Bharat can see, is between pembrolizumab and cetuximab. So why are even having a debate? The previous study that was done was in 2008. That was platinum-based chemotherapy plus cetuximab in head and neck cancer. And straight away, the first thing that we need to understand, cetuximab is not a targeted therapy in the sense that it gives you a target. Remember, cetuximab alone does not have any activity in any cancer. It's a good drug probably. I'm sure Dr. Bharat likes that drug. But remember, it does not have activity on its own. Whereas when you look at the above study, it is pembrolizumab alone or with chemotherapy. So both ways it does have its own action. Still, Dr. Ashish has asked me to do this debate. So let's continue on this debate. Next slide. So let us see first the two groups. So this is the classic thing that we always do. Are the two trials similar? Are they looking at same populations? Are we in fact treating the same disease? The majority of things that we need to look at the same. The populations included chemo patients who were having recurrent, relapsed, locally advanced or metastatic head and neck cancer. They could have had surgery or radiation, but chemotherapy in either systemic form or with radiation should have been more than 6 months back. So both the trials used the same population, right? Endpoint used was overall survival and PFS. Now, because you have a 3-arm study in the pembrolizumab arm, we did have end of around 14 different endpoints. 11 of them were superiority, 3 were non-inferiority. A cetuximab trial was a little bit more modest. It only looked at the basic 2 endpoints of OS and PFS. Number of patients, fair enough, you had around close to 300 in the pembro each arm, whereas the cetuximab had around 200 in each arm. Now the 3 arms were pembrolizumab alone, pembro with chemotherapy, or cetuximab with chemotherapy. Now the chemotherapy was similar in both the groups. Used a platinum and 5-FU. Platinum could be cisplatin, could be carboplatin. In the keynote, it is around 46% for carbo, 53% for cis. In the extreme, it was around 30% for carbo, 40 remaining for cisplatin. So again, doses of the 5-FU, doses of platinum, cetuximab, all are same. So how is it different? Next slide. For me, the biggest difference, other than the fact that you had a 3-arm and a 2-arm thing, in the keynote, there was no chemotherapy alone arm. This is important. Yes, we know that there have been studies like the Extreme, we had studies like Attempt. We do have later on studies which looked at cetuximab versus chemo. However, the keynote study did not include a chemo alone arm. The biggest difference is that there is no biomarker for cetuximab. Now, I don't know if Dr. Bharat will be showing this to you. The cetuximab arm tried to look at a biomarker. It looked at EGFR expression, in which 98% had EGFR expression. And in no study till today have we been able to identify who are the patients who are going to respond to cetuximab. So in other words, give it to everybody. It's what you call the wash sink approach, where you throw the kitchen sink at the wall and know what was eaten for dinner because you can find what was stuck on the wall. So that is something what cetuximab does. Give it to everybody without knowing who are the ones benefiting. Whereas when you look at pembrolizumab, you had the keynote 040, where you had a subset analysis which clearly showed you that those patients with higher PD-L1 expression, as shown in the CPS or as shown by the amount of expression, did better with Pembro. And that is the basis of this study, where they had previously itself predefined PD-L1, CPS more than 20%, CPS more than 1%, and the PD-L1 levels. So that tells you that you have a biomarker that will identify which patients will benefit with the Pembrolizumab. Next slide. So let's jump straight into the overall survivals, because that's what is important. Dr. Ashish showed us that head and neck squamous cell carcinoma is not a good cancer. It is not one where we are looking at long overall survivals. We are having short overall survivals. With chemotherapy alone, it's around 6 to 8 months. Now, when you compare that with what we are seeing in the Extreme study, look at the 1-year OS for this group, which is the CPS more than 20. You have 57% overall survival for Pembrolizumab, which is 45-year, not too different, you might say. But over time, at 2 years, it is still 38% in the Pembrolizumab. So you have approximately 2 out of 5 patients surviving in a Pembrolizumab arm, significantly better than here. Then, what about the Pembrolizumab alone in patients who are more than CPS 1? Again, showing an improvement. More importantly, look at this end. You're beginning to see the tail that we all like to see with immunotherapy, and we all know that immunotherapy gives you this tail. When you looked at CPS in the total population, that means CPS 1, less than 1 everywhere, there the benefits probably shrink. And again, it just highlights what I was telling you. You have a biomarker, and that decides whether Pembrolizumab monotherapy should be used or, next slide. Look at the OS with the combination chemotherapy. Again, 57 to 46, 35 to 39. When you look at the CPS more than 1, again, the numbers are slightly lower, but you continue to have a benefit when you see the combination with Pembro or as monotherapy alone. Overall survival, I don't see what else is there to debate. Next slide. Still, let us look at other things. Let us look at the efficacy endpoints. Look at the OSs and look at the hazard ratios. 0.71, here it is 0.86 in a selected group. Agreed that not everybody should be given a Pembro monotherapy. I think that is for clear. But anyone who is more than 20% CPS should be given. In fact, this group is the 1 to 20 subgroup. Even here, you're seeing a monotherapy giving you an OS benefit and a hazard ratio, which is, well, not matched in this group, but the combination takes care of it. Next slide. Next slide, please. Looking at the duration of response. Again, Pembrolizumab monotherapy, it's around 10.8 months OS. Duration of response not reported. And duration of response is better than the standard treatments. Next slide. Let us again look at the CPS less than 1. Here, when you give monotherapy, well, not beneficial, but again, that's something that's expected. At least you know which patients you should not use Pembrolizumab. That is again important. And that is something which the Extreme trial never been able to tell us as to which patients are not going to benefit from Cetuximab. Next slide. So when you look at TPS, look at the difference score. Again, look at this difference. Very, very nice separation of the curves right from the beginning. So you can further distill and enrich your population by using either TPS or, of course, the CPS more than 20. Next slide. So what does Extreme show here? Look at this end and look at the hazard ratio for the OS. Now you can say that OS is beneficial. It's 0.99 with a hazard ratio of 0.8. Not as impressive. 1 or 2 patients here and there and your hazard ratios would not have mattered. Look at this. The slides are almost matching. You're not really having a difference. And in a scenario where you are going to have a second-line drug possibly, or even if you use immunotherapy first line, follow it up with your chemo, follow it up with Metronomic, you're still going to have a separation, not seen with Cetuximab. Yes, PFS looks better, but not the OS, what really matters. Next slide. What about if we use a different analysis? Now, restricted mean survival time is something that has been pretty much validated. What this means is you kind of keep seeing how much the effect of immunotherapy lasts over time. And when you look at that and look at 36 months RMST, Pembro chemo versus Cetuximab, CPS more than 20, you're having 18.6 months versus 14 months, so 4.5. 17.3 versus 13.5 in CPS more than 1. Both the groups, you are having the benefit. When you look at monotherapy, again, look at this difference of close to 6 months with a CPS of more than 20, and that really is the key. Next slide. What about toxicity? Now, the fact remains that all of us have used cetuximab, and we all know it is not as simple to use as, say, any other drug. Looking at the grade 3-4 toxicities, 82% for cetuximab versus 76 for chemo. Grade 4 virtually equal at 31-31. Keynote for 048, when you looked at grade 3 and above, Pembro monotherapy, only 55%. Not less, but significantly less than 85 versus 83%. QOL data is awaited. I'm sure QOL is going to be better for Pembro monotherapy. Again, that's something which is pretty much what we are all using on the ground. Next slide. In a nutshell, to clarify, CPS more than 20, you have monotherapy with OS benefit, significantly less toxic. 1 to 20, Pembro is non-inferior, better tolerated. If you use Pembro chemo, you're superior and equally well tolerated. Less than 1, chemo Pembro better than chemo alone with cetuximab. In all cases, PFS is non-inferior. Yes, PFS advantage is not going there. But remember, this is a bunch of patients who are anyways having a poor outcomes irrespective. So I would be more interested in getting my OS. Next slide. Costs wise, yes, Dr. Bharat sees very rich patients and who can afford everything. But remember, that's true for cetuximab. This was the argument we all use for cetuximab when we talk of cetuximab versus chemo, that you need rich patients, you need rich doctors. However, compared to cetuximab, Pembro is almost equal. And it's not just me who is saying it. Next slide. This was told by the NICE guidelines. Now, NICE, remember, is notorious for looking at the costing. Next slide, please. And the NICE has commented that Pembrolizumab can be recommended for all patients whose tumor score is more than 1 or more. And they have written that though maybe slightly different, the overall costs are lower and it is equally effective. It is better and less costly. So you cannot give a routine argument that we use in all our debates that it is more costly and don't use a costly medicine. Next slide. So finally, NCCN, let's just take that little crutch as well. None of us are huge fans of NCCN in all its glory, but however, I think once they have gotten it right, a preferred regimen in a recurrent, unresectable and metastatic has to be Pembrolizumab platinum and 5FU in a category 1 preferred, or for patients that express PD-L1 CPS more than 1, definitely you should use Pembrolizumab monotherapy. If it is more than 20, then I don't think we need to even discuss. Next slide. So Dr. Bharat might feel that he has a bestest thing available with him. Next slide. However, sticking to cetuximab is like the dinosaurs who, next slide please, is like the dinosaurs who kept on looking at the comet while it came out on an asteroid that came and hit them. So thank you very much. And I wait with pleasure to hear what Dr. Bharat has to say.
Thank you, Vamshi. It's a nice presentation. And I think you rightly pointed out, this both category of the patient, whether who can afford for pembrolizumab or cetuximab, these are the really rich patient. I think I'd invite Dr. Bharat Aswani for in favor of non-immunotherapy treatment. Bharat, now it's...
Let me thank the organizer, sir. Absolute pleasure in speaking. That is my dream topic, is to speak about TP Extreme. Slides are visible and am I audible, sir?
Yeah, absolutely.
So listen, absolutely wonderful debate by Dr. Vamshi. What I am trying to tell is, in spite of everything, you need to understand when we talk about a patient with head and neck cancer, which is the best sequence which will give the maximum overall survival. When you talk to the patient, the first question is, sir, मैं कितना जीऊंगा? So what is my overall survival? And I'll be telling you that by following my sequence, that is TP Extreme, that is the best survival you can get, because there are 5-6 active agents when you have a cancer. You have a platinum, you have a 5FU, you have a taxane, you have a methotrexate, you have a cetuximab, and you have a immunotherapy. Now, getting one drug in the first line, you don't have anything in the second line. So by getting your sequence right, you are sure to get the best overall survival in a patient with head and neck cancer. And that is what I'll be telling you, and I'll be telling you entirely the facts which are there. Something that you need to know, because that is what we have worked very hard to prepare these presentations. Now, what are the goals of treatment in a cancer? There are 4 goals. The tumor should regress, So you should have a good overall response rate. You should stop progression of disease. So you should have a good PFS. Definitely, you should have a good quality of life, because longevity is not important. It is the quality plus longevity which is important. And the most important thing which takes away all the cake is the overall survival. So what is the way you should treat a patient? That is the way you can give the best survival to your patient. So TP extreme is not an extreme. Now that is where what the point lies. You don't have to give 5FU, because the immune responsiveness increases when you give taxanes in the first line. That is a thing all times I am trying to discuss. So this is a regimen which has compared the standard of care at the other arm, what was discussed by Vamshi, Cetuxi cis 5FU with cetuximab maintenance, with the drug that I also follow in my practice. That is combination of docetaxel with cisplatin in a single dose, single day schedule with only 4 cycles, with cetuximab, followed by cetuximab maintenance in a 15-day schedule. So the regimen is not weekly, it is bi-weekly in a maintenance form. This was based on the earlier study of TPX Gore-Tex study, which was from the same author, Gigi et al. This study had shown a very encouraging overall response. Just look into it then before I proceed. So this was a big phase 2 confirmatory randomized study, which compared docetaxel-based first line along with cetuximab, followed by immunotherapy and or chemotherapy, followed by the other treatment. So this was a trial design. I will like to concentrate on the point how I treat my patient. So newly diagnosed relapsed metastatic head and neck cancer with a good performance status with an adequate creatinine, only 4 cycles of chemo, and that is most important. You don't need a 6 cycles of chemo in a metastatic setting. We have seen in breast also, in a lung also, you give 4 cycles and you go to maintenance. That is what it had followed. You had a cisplatin, you had a docetaxel, and you had a cetuximab, followed by a maintenance cetuximab every 2 weekly. A 4 cycles with a single day schedule, as against a big schedule of my other arm, or against a Pembrolizumab, which is a 4-day schedule. So that is the advantage. Now try to concentrate on the overall response rate. 46%, better than a chemo with a Pembro or a single agent Pembro, which is not more than 36%. Agreed, that is no. Look at the overall survival, 14.5 months. Now, when you look into the best of your subset, that is PD-L1 more than 20, it was 14.8 months. So this overall survival is as good as anything. Now the problem comes is, they may say that it was not statistically significant, but the problem was in this trial, Extrema also did well. But the most important thing is you had a drug which has in a single day, in a 4 cycle, has given an excellent overall response rate with one of the best overall survival. Only 4 cycles. The most important thing comes here. Tell me any study which shows such a good toxicity profile. 10% only delay, cisplatin only change to carboplatin in less than 10%, only 34% higher toxicity. You see the other drugs of memorism, I will not discuss, and 3/4 of the patient went on to maintenance. So 4 cycles in a platin dosi with a cetuximab followed by cetuximab has given you a survival of 14.5 months. So a very good response. I will tell you why it is good than other also. But it is 14.5 months as per as a single day schedule. The point is probably this was not highlighted because it was not statistically significant, but let us see the quantum of benefit and let us see how the second line also works. Now here comes the main case. Everybody talks about immuno. Look, there is only one drug which has given OS advantage in the second line, that is immunotherapy. So once you utilize immunotherapy in the first line, you have nothing in your second line. Vamshi told my work, cetuximab has no role in the second line. So what about, you can't waste a good drug here. So here comes the main thing. Around 17 to 20% of them took immunotherapy in the second line, and 44% in TP exam took chemotherapy in the second line. Now, when you look into it, those patients who are given docetaxel in the first line and followed by immunotherapy, see the OS. Absolutely, I don't want to debate anything for that. 22 months is the OS for a patient who took immunotherapy in the second line which was preceded by taxane. Now, also look at the OS at 36 months, 24, 12 months. Look, what I want to stress is, initially you need to give a drug which is more robust acting. Immunotherapy can come in the second line, which can cause your tailing of the curve. So if you utilize your combination in the better way, you will definitely get a survival which will be close to 2 years, which has never been achieved. So it is not patient who is intelligent, who has that best way to give the treatment, and that has been followed in other organs. Now, this is also most important. Those patients who take taxane in the first line, immunotherapy works better in those who take taxane in the first line, and that has been shown by this. So 11.6 months was the median OS after randomization in the second line who took docetaxel-based chemo, and that is because of what we call as immunoadjuvant effect of paclitaxel and cetuximab. What has already been proved is paclitaxel increases tumor-infiltrating CD4 and CD8 cells and reduces T regulatory cell. But what has been shown is once you combine it with cetuximab, this immunogenic response is enhanced. So it doesn't enhance the efficacy. It also enhances the immunogenic potential of the second line. And that is what you need to understand. If you have to utilize your immunotherapy, please give it in the second line, not as a first line, because the best immunogenic response comes when you combine paclitaxel with cetuximab. What about quality of life? That has not been mentioned. So better quality of life when you use docetaxel, again extreme, and that is what we say. It is not the longevity, it is not the response, but it is equally the quality of life, and here also it scores over it. What about other parameters? So everywhere, including emotional, cognitive, social, and everywhere, this drug scores over the standard drug and has an acceptable or even encouraging, or I can say the best response when you can sequence it with IO. So this trial tells that there is 14.1 response, very less toxicity. More importantly, those patients who took immunotherapy after docetaxel had an overall survival of 21.9 months. More importantly, improvement in quality of life. Now, you say, I have told my other thing. Now I will try to tell you, do we have an Indian data? Everywhere it comes down to, we have foreigners. So there was a poster presented by Calcutta group when they compared this TP extreme, and you see this survival is as good as the survival which was given in the standard half. So Vivek and his group had presented a poster in this ESMO Asia. What did they show is, when you give this combination, the survival is again 21 months, and that is what it is a detail. So those patients who were able to take IO in the second line, they had an overall survival of 20.9 months. Overall also it was 15 months as an overall survival. So you take Western data, you take Indian data, the data remains more or less consistent that if you take TP extreme in the first line and you take immuno in the second line, your survival is more than 20 months. Now, let me discuss some points about Keynote 048. Absolutely what Vamshi said, I agree with it, but I will try to present it in a different way. If you have time, go through this European Medical Agency of the assessment report of Keytruda, where they presented for 048 study. This study had 8 amendments. So I don't know how was it randomized. If you see this, for the first 600 patients, they took patient with any number of PD-L1. But when they realized probably the study may not be important, the last 180 patient was there with strong PD-L1 expression. So they were biased in taking those with a strong PD-L1 expression because they realized this, that once the PD-L1 expression is less than 20, they don't give that benefit. And that is what I'll be telling. This is entirely based on this subset. Vamshi has told CPS more than 20, CPS more than 1. Now, please see those patients other way around. What if you remove the CPS more than 20? So the OS is only 10.8 with a single agent Pembro, and if it is less than 20, which includes 0, in fact, it is equal to extreme study, which was there. Now, if you look into less than 1, it is less than extreme study. Now, when we deliberate about Pembro with chemo, just see less than 20. So you remove the CPS more than 20. This quantum of benefit is less than 2 months. So if you have 12 CPS, you may not take it more than 20. That is what these are intelligent people. When they more than 1, it includes 1 to 20 and more than 20. I've tried to say less than 20. And when you say CPS less than 20, 11.8 versus 10.2, it has included. And if I include only less than 1, this quantum of benefit is less than 1 month. So whatever this trial has shown is there is a OS benefit for more than, so this is only because of CPS more than 20. If you look into that less than 20, including 0 or less than 1, this quantum of benefit is less than 2 months. And here we are talking about 14.5 months and 21 months. So that is because if you give immunotherapy in the first line, what is the second line you have? You have nothing, you have only taxanes. That is what I am trying to tell. Give a good active drug in the first line and give a drug which has a proven efficacy in the second line and OS advantage. Again, the same thing. If Pembrolizumab evidence clear in CPS 1 to 20, see, more than 20, 14.8. If you take only 1 to 20, they have deliberately taken CPS more than 1 only. If you see 1 to 20, it is 10.8 months and only 20.7 months when you take Pembro with chemo. And that is what we need to understand. More than 20 may be a good drug, but less than 20, you should not. Every good thing, just try to look into progressive disease in those in Pembro in less than 20 and less than 1. It is half of them progressive, so no response at all in less than 50. The same thing has applied in when you take with chemo combination. So there is a high progressive disease in those where CPS is less than 20, and here you should be careful. It is biomarker driven, I agree, but biomarker only more than 20 has advantage. There is none that. And my last point, there is a very shorter survival with when you have a progressive disease as evidence that by those patients who did not improve at all. This is the what is a last golpe fixer. Now, those patients who had just see 4-year survival in those with PDL1 more than 20 and more than 1. Out of 22 patients in CPS more than 1, 17 patients were there who PDL was more than 20. So if you think of your patient, 130 patients in 1 to 20, only 5 patients had a long-term survival who were between 1 to 20. Again, reiterating the fact that the responses or the advantage of what is there in Pembro more is only in CPS more than 20, because only 5 patients, if you see. The same applies to Pembro with chemo. If you see CPS more than 20, around 22 patients was out of 126. And you see overall more than 1, it is 29. So only 7 patients with CPS 1 to 20 survived for 4 years. So that is what I wanted to tell. Why TPA Extreme should be the best go-to drug, because overall it has a better ORR, better PFS, and equivalent or better OS in the entire population, irrespective of PDL1. I'm not seeing any PDL1. I'm starting my patient on cis-dosi cetuximab followed by cetuximab. For a subset of patients where I am lucky, if it is in my hospital maybe, where I can give cetuximab taxane followed by immuno, this survival is 21 months. We have data from Indian population now also. So this drug is the combination absolutely applicable. And this is the most important thing. You should be careful. I think so. You should be like Rahane, not like Rishabh Pant like today. Rahane scored 100 because the survival of second-line immunotherapy utilized in a better way by giving immune adjuvant effect of taxane in the first line. So when you are giving taxane and cetuximab for the first line, that immune responsiveness comes in the second line with immunotherapy. And in fact, everybody will agree that the only drug which shows overall survival advantage in second line is immunotherapy. So this is the take I should have. How do you treat your patient? So the best way to treat your patient is you have to sequence by utilizing all the active agents in a better way, which leads to overall survival improvement. So that is my final slide. My take is first line should be TP Extreme, because then you can give immunotherapy in the first line and maybe metronomic therapy or methotrexate or Palliative in the third. I thank you all for a patience here.
Thanks, Bharat, for the nice presentation and some of the very interesting data. I think, Vamshi, you want to cross?
Oh, sure, absolutely. So, number one, I thought we were debating extreme, but we ended up debating TP Extreme. No problem. What Dr. Bharat did not tell you about the TP Extreme, that it is actually a trial which was designed to show that TP Extreme is better than Extreme, and they were looking at a hazard ratio of 1.21, which they very nicely failed. And therefore, they said that TP Extreme is at best equal to Extreme. Remember, it was 14.5 months for the TP Extreme and 13 point something for Extreme. So TP Extreme is not much better. If anybody who looked at the trial design noticed that every patient in the TP Extreme would be given PEG GCSF or GCSF, whereas Extreme did not have that. So obviously your toxicities in terms of grade 3, grade 5, in terms of neutropenia and all would be lower, very elementary. Next, what about the Indian data that he was kind enough to show us? Now that Indian data of Dr. Vivek had 54 patients, or which if I could read, of which 19 went on to take immunotherapy, and there, yes, you did get a benefit. That also brings me to the other point Dr. Bharat did show us, that yes, in those patients who managed to get immunotherapy in second line, you can achieve 21. Is that for all comers? No. It is only for that 50 or 60% of patients who are still able to go for a second line. So the second line myth that we say that all patients will go for a second line is not simply true. In fact, it is those patients on a single agent first line who would be more likely to have less toxicity and be able to go for a second line. So sequencing is important. but just not the order that Dr. Bharat has told us. Remember, we are in personalized medicine. We are going to start a trial in India itself for alpelisib in second line, because almost 40 to 50% of head and neck cancer patients do have PIK3 mutant. So that is where we are looking for. And finally, to end with the cricketing analogy, Rishabh Pant is a wicketkeeper and Ajinkya Rahane was a batsman. So you look for a batsman, and it's precisely the point what immunotherapy is. It's a batsman. It actually attacks the cancer, not like cetuximab, which is not doing a primary job of batting. Okay. And again, at the end, like all debates, like my teacher, Dr. Kumar says, in a debate, we do tend to take extreme positions. So nothing but too much should be read into what we actually do in practice. So thank you, Manoj.
Sir, can I put a last comment, sir?
Yeah, sure. And especially,
sir, listen,
my question also.
Nobody denies that immunotherapy has a role in head and neck. What I am trying to tell is that immunotherapy has a role in a subset of a patient. For a patient to get a maximum survival, you have to have all agent utilized. And that is the problem that comes. The moment you give immunotherapy in the first line, you don't have nothing to give in the second line. And also, probably everybody agrees that progressive disease as a whole, probably in head and neck is more than what is in the other cancer. So that hyperprogression phenomena came basically in a head and neck cancer. So probably this trial, people are very smart. When I read this article entire, there is a subset of patient which benefit, you can think of it. But for other subset, that quantum of benefit is not there. And when we talk about a drug, you have to give the best drug. And patient aphytum, I don't think so 4 cycles will deteriorate quality of life. In fact, I mentioned the toxicity also, sir. So most of the time, 3/4 of the patient are able to take this 4 cycles. Problem comes in the later part of the chemotherapy. And that is why this trial is good in the sense it utilizes chemo to the maximum effect, where it works. Secondly, it utilizes immunotherapy to the extent where it works. And here, only one drug has a survival data in the second line. So by utilizing all of them in a good way, the best way is to give all the agent where it should be used at the best time. So best drug, best time, best place in a best person will use the best survival. That is what best.
Thank you, Bharat. I think
Good.
it's a nice comment. And I think we are doing the cross-trial comparison. That is a limitation because we don't have a head-to-head comparison of TP Extreme versus Keynote. But there are the certain important points which probably I think come up with the subgroup analysis. I think you rightly pointed out, like in TP Extreme, we can avoid the 5FU because it's very easy to administer one-day regimen, very well safely tolerated, and you can do the subsequential treatment. But what we have a landmark phase 3 study, which I think Dr. Vamshi is also right, as well as far as available data, Keynote 048. But I think for Indian patients, there's a lot of limitation. I think we need to understand because right now we don't have any the 5FU is one of the toxic regimen. We don't have any patient assistance for Pembrolizumab for the first line. So considering the toxicity, cost, and all put together, I think very easy to administer TP Extreme. But we need to understand TP Extreme is designed for quality issues. It is not showing a superior survival over the extreme. So the trial was compared as a non-inferiority regimen over the extreme, but there are the quality of life benefit over the extreme in a TP Extreme study. So with this, I think I thanks to both the speaker for a nice presentation. I think we'll continue our further discussion in our panel discussion. We have now we have the second debate. I think I invite Dr. Shruti Kate for the second line treatment and recurrent metastatic head and neck cancer. Dr. Shruti, she's going to speak on favor of immunotherapy.
Yes, sir. I'll just share my screen.
You have to put the enable editing. So that is important. Just click the enable editing. Yeah. Yeah, please go ahead.
Thank you, Dr. Kaushal, for inviting me for this debate. And like Dr. Vamshi said, so some things they speak for themselves. So I understand the sentiment behind keeping this debate, and I am not Dr. Vamshi, so it will be easier for my opponent to make a point. So really, why are we considering a debate for second line treatment of advanced recurrent head and neck cancer? Let me put my emotions to you and you'll understand. So head and neck cancer is a very immunosuppressive malignancy, and we know that the tumor mutation load varies in various types of patients, and there is an interplay between the smoking status, the HPV positivity, the anatomical site, and various mutations that determine the tumor mutation burden. And hence, these tumors may either be immunologically cold or they may be hot. So the intention is that we should utilize the patients who have head and neck cancer by giving treatment which makes the tumor immunologically hot and enhances the effect of CD4 positive, CD8 positive cells in the tumor microenvironment, which results in tumor death and increases the overall survival of the patient. So there is a complicated interplay of these receptors at the level of activated T cell, exhausted T cell, and the effector T cell. And this is exactly where we are focusing to cut this pathway and subject the cell vulnerable to body's immunity. So we are all familiar with the NSD1 mutations and how NSD1 mutated tumors are immunologically cold. And there's no way to know how the patients are going to behave when you subject to a second line treatment. We do have biomarkers, but we do not know what is exactly the tumor mutation burden for that particular tumor when we are planning the treatment. So the most effective way of dealing with a head and neck cancer patient in the second line setting is to see whether the tumor is immunologically hot or cold and subject the patient to immunotherapy and give the best overall survival. So what we already have is extreme and we want to go beyond it. So if you look at the first data that comes for immunotherapy in a second line setting is Checkmate 141, where the patients who had progressed or recurred in less than 6 months after the last dose of platinum based chemotherapy, be it in the radical treatment part or in the metastatic part, were randomized into 1:1 ratio to immunotherapy nivolumab 3 mg per kg every 2 weeks against a treatment of investigators' choice, which include any and every chemotherapy drug that we know in head and neck cancers or cetuximab. And the primary endpoint was overall survival. Other endpoints were PFS, ORR, duration of response, safety, biomarkers, and quality of life. So here, this is important to see that immunotherapy in the patient population which this study catered to, around 60% of patients had already received cetuximab in the previous line of therapy, and majority of patients had at least one line of therapy which they had received, and not a very small number, 1/3 of the patients had already received 2 lines of therapy. So these are the patients who really do not do very well when you subject them to best supportive care. So this is the overall survival result. And you can see here that 36% of patients survived beyond 1 year in the nivolumab arm versus 16% in the standard therapy arm. And if you look at the median overall survival, it was statistically significant. But the important point here was how these curves separated at 3 months. So we know that for some patients, for whom the tumor is immunologically cold or are not going to do well on immunotherapy, but once we have left out those who are going to hyper progress, the curves separate such beautifully, and this is exactly what you want to see in any paper. The response which is deep, which continues for a long time. And if you look at the 2-year overall survival, it is 16.9% for the nivolumab arm versus only 6% for the standard therapy arm. Again, like I said, all the stratifications that were possible were done for these patients to see, was there anything that was not suiting to immunotherapy or nivolumab for that matter. But in each group of the stratification that was done, nivolumab fared better. So there is something also important to note: what happened after progression. So this is checkmate 141, nivolumab treatment beyond progression. So what happened was that these patients post progression were predefined for a protocol specific criteria where the investigator assessed the clinical benefit. There was no rapid disease progression. Nivolumab was well tolerated. There was a stable performance status. There was no delay of imminent intervention to prevent progression associated serious complications. And after, of course, an informed consent, these progressed patients were given a choice of treatment beyond progression. And out of these 61% who had progressed on immunotherapy, 42% were treated with nivolumab beyond progression. This means that even though they had progressed radiologically, the progression was not very clinically significant. And this is exactly what you want. You want a progression which is milder, maybe at just one site, or maybe some new nodules coming up, something where you just ascertain that this patient can be treated beyond progression. So what happened to these patients, you can see here that following the first progression, 24% had target lesion reduction, out of which 3 patients had more than 30% reduction and 5 patients had more than 20% increase in target lesion at first progression. So if you see here, this is the strategy what you want to use when you are choosing the patients for immunotherapy. You want to give a treatment which tries to control tumor for the longest duration of time. Another immunotherapy agent, Pembrolizumab, which was compared with the standard chemotherapy agent, chemotherapy of investigator choice for the second line treatment was Pembrolizumab in Keynote 040. If you look here, again, the patient population was little different, and hence the difference that you will see in the overall survival results. The patients who had progressed 3 to 6 months, so they deliberately removed the patients who had progressed within 3 months. But again, post less than 2 prior lines of treatment in recurrent metastatic setting, ECOG PS0 or 1, and availability of tissue for assessment of PDL1 were the inclusion criteria. Here again, pembrolizumab in the standard dose of 200 mg IV every 3 weeks was compared with the standard of care. Again, within the standard of care, cetuximab was also allowed, and for those who had not received it. And these patients were stratified as per the pre-specified endpoints, specified subgroup analysis. For a primary endpoint was overall survival in the intention to treat population. Secondary endpoints were OS in PD-L1 positive patients, progression-free survival, overall response rate, duration of response, safety, and tolerability. These are the overall survival results in the intention to treat population, and very well comparable with Opdita here. 12 months 12 months overall survival was 37% versus 26.5%, and the median overall survival was little higher because of the patient population, which was little different. But what we want to see here is that in both the populations which had CPS more than 1 and TPS more than 50, the median overall survivors was way increased. If you look at the 12-month overall survival, it was 46.6% for TPS more than 50 versus 25% for the standard arm. Again, in these patients, around 60% were already exposed to cetuximab. So what I'm trying to say here is there is no other option currently available for these patients to go on to use something and increase their life. And if you look at what was seen in the forest plot, every population did benefit from pembrolizumab except the CPS score of less than 1. And this is exactly where you can subdivide your patients and choose those who will derive the maximum benefits. So more important than the overall survival is preservation of the quality of life. And it is important to note that the frequency of adverse events were 2.7 times lower with pembrolizumab than the standard of care. Again, the median duration of response was 18.4 months in the pembrolizumab arm versus only 5 months in the standard of care group. Certain other immunotherapy agents which have been utilized in head and neck cancer, one of them is durvalumab, and again responses and overall survival is similar as compared to nivolumab and pembrolizumab. The HAWK trial. So these are the 3 agents that are currently under investigation, and 2 of them we know are already approved for the second-line treatment of head and neck cancer patients who have advanced disease or are metastatic. So these are the approved indications for second-line treatment: nivolumab, pembrolizumab, and durvalumab, atezolizumab are currently under investigation, have not derived their approval. So, the same NCCN guidelines, here you can see that in the second line treatment or subsequent line treatment, if the patient has not received immunotherapy in the first line setting, nivolumab, pembrolizumab are the only agents that are approved as category 1 indication. If the patient has not received the other sort of all these other agents are category 2B indications, and there is no place for what we are debating against. So what we already have is what we have, but we have to think outside the box and utilize immunotherapy to the maximum benefit. I agree that head and neck cancer, advanced or metastatic, is an unmet need of our country, and what we have is not what we are totally satisfied with. What we need is something to enhance the effect of immunotherapy. We need something which is turning the cold tumors hot, and there are various other possibilities that are being explored all over the world. Combination of immunotherapy with radiotherapy, combination of 2 immunotherapeutic agents, combination of immuno with chemotherapy, and immunotherapy with a targeted therapy. This is something interesting that is happening, and we await what the final results are. So this is a combination of durvalumab with tremelimumab versus durvalumab monotherapy versus tremelimumab monotherapy. And this is what we need. Here, the population of patients that has been chosen is PD-L1 low or negative. So why are we discussing this versus metronomic chemotherapy? So what is metronomic chemotherapy? Dr. Pinaki will tell us in detail, but it is, what I know is it's a poor man's immunotherapy. We know how metronomic chemotherapy works, but as of now, it has never been come up into a standard therapy. He is definitely going to put up this paper, and nothing that suits our pocket has, as of now, made it to Lancet. And this is a very interesting, important paper. But what we need to know is that the authors have concluded that oral metronomic chemotherapy is not an alternative if alternate options of immunotherapy are available. There are serious reasons to this. Patients who had progressed on treatment beyond treatment with metronomic chemotherapy, how many of those received immunotherapy? They have just mentioned that 2 in each arm went on to receive immunotherapy, but what happened later, we are currently not aware. So where we need to utilize metronomic chemotherapy, as of now, we don't know. But yes, a combination somewhere with immunotherapy which turns the cold tumors hot is the only place I can think of as of now. So it will be interesting to see how Dr. Mahato puts up his emotions. So to summarize, immunotherapy, again, an important thing which may suit to our pockets, like the only debate happening would be the cost issues, but I don't see cost as a barrier in practicing what is evidence-based medicine in a scientific meeting. But yes, there are interesting papers. There is one interesting case report mentioned as a letter to editor by the TMH group, where nivolumab was used in a low dose to in one of the patients who had progressed post oral metronomic, and the results were very, very good in that. So we need to devise our sort of immunotherapy which suits our pocket. So what they had done was use 40 mg every 2 weeks, and the patient did very, very well. So we need to, but how many of us would be putting a randomized trial of immunotherapy in second line setting versus metronomic chemotherapy alone? Maybe metronomic chemotherapy with immunotherapy, or subsequently with immunotherapy, some sort of a very unique design to prove that it holds some meaning in treatment of recurrent metastatic patients in the second line. So immunotherapy has already an established place in second line treatment. We all are aware, but we want current studies to evaluate immunotherapy in earlier stages in combination with other immune modulators and in the context of standard chemo radiation to increase the overall survival of these patients, because it is still an unmet need. Thank you so much for your patient hearing.
Thank you, Dr. Shruti, for the nice presentation on the immunotherapy on the second line management of advanced and recurrent head and neck cancer. I invite Dr. Pinaki to speak about in favor of metronomic chemotherapy or other than immunotherapy as the first line.
A very good evening to all of you. Am I audible?
Yeah.
Yeah. So it has been an academic feast so far, and I'm really intrigued by all the conversations. I think, see, Dr. Shruti, it's not a debate that whether we should use metronomic versus immunotherapy. That debate is not there because the median survival is inferior for metronomic therapy. The debate is whether our patients can take immunotherapy on a regular basis. For us, when we are sitting in our OPD and treating our patients, the conversation is over in the first 5 minutes when the patient says that I am not affording for immunotherapy. So then it becomes a debate at whether the patient is going to go for chemotherapy or metronomic therapy. As you said rightly, it's difficult to even do a cross-trial comparison, We are not sure. The only thing probably is that probably in the future, probably we can go for further combinations of metronomic or immunotherapy. As you rightly pointed out, the seminal trial that TMH has published in September in the Lancet, I'm going to discuss that. And I'm just going to point out my things, what I feel, where metronomic therapy has got a role. Next slide. So we know that the NCCN, they have included regimes, as Dr. Shruti pointed out, but they have got very low applicability in our country, in low income and middle income countries. The phase 2 study that TMH did in 2015 showed that people who receive metronomic had better outcomes as compared to intravenous cisplatin. So again, the control was intravenous cisplatin, but this is again a common standard of care that we use in our countries. So this was the basis of the non-inferiority phase 3 TMH study that was conducted between 2016 and 2020. Next slide. So standard palliative systemic therapy includes the extreme keynote, as you have pointed out, the Checkmate 141 and the keynote 040 trials. The 2-year survival definitely, as you pointed out, was superior than for the metronomic therapy. But whether in our patients it is practical or not, whether our patients who can afford it or not. So in those patients, definitely the authors of the article have said that definitely the use of these regimes should be preferred in patients who have access to them. But in patients who do not have access, and even if you look at the toxicities were quite high. So if patients, they want a less toxic alternative therapy, oral metronomic therapy can be offered to these patients. Most of our patients in India, they come from the lower socioeconomic strata. The general condition is generally not that good. And definitely, they definitely want a therapy which is less toxic as compared to the conventional therapies. Next slide. So the 2015 TMH phase 2 study had 110 patients. The primary endpoint was progression-free survival. Here we can see there was a clear separation of the curves from early on, and which was maintained even after 100 days, 200 days. And the PFS, the hazard ratio was 0.63, and the confidence interval is less than 1. So even the overall survival hazard ratio was 0.61. So it was definitely metronomic therapy winning over single agent cisplatin when we talk about both the arms. Next slide. Even in the overall survival, as I said, it was statistically significant. So definitely there was something going on, and metronomic therapy was proving to be a winner over cisplatin. Next slide. If you look at the factors that that affected the overall survival, it was mostly the disease, that is oral cavity subset versus non-oral cavity. Non-oral cavity did better. The treatment-free period, where the treatment-free period being more than 6 months, it was better survival, and definitely the performance also made a impact. Next slide. So this was the basis of the phase 3 Tata study, and it was an open label parallel group non-inferiority randomized phase 3 trial, which included patients who were 18 to 70 years old. They planned to receive palliative systemic treatment for relapsed, recurrent, or newly diagnosed. Even newly diagnosed patients, they analyzed them in the MDT, and if they found that they were not amenable for the localized therapy, almost half of those patients who come, definitely we find that even in the first presentation, they are not amenable for the localized therapy. So those patients were also included in this trial. Definitely the performance was 0 to 1. It was measurable disease and adequate end organ function. Next. Patients with primary tumors in the salivary gland, thyroid, nasopharynx, uncontrolled comorbidities, and those patients who had progressed within 3 months with cisplatin, they were excluded. Patients unable to swallow tablets, as assessed by investigators, are also excluded. Next slide. So this was a treatment schema. Out of 594 patients initially assessed, they included only 172 because 105 did not meet the inclusion criteria and 67 were unwilling to participate. Out of the 422 randomly assigned, 50-50 in a 50-50% way, 213 were assigned to the metronomic arm and 209 were assigned to the intravenous cisplatin arm. And eventually they were including the intention to treat analysis for efficacy as well as for the primary endpoint. Next slide. So oral metronomic therapy, methotrexate 15 mg meter square once every week, plus 200 mg celecoxib twice per day, commonly used regimen by most of us. And intravenous cisplatin was 75 mg per meter square. Intravenous cisplatin, it was not 100 mg meter square because most of these patients were already received cisplatin previously. And that's why it was kept 75 mg per meter square, maximum 6 cycles. The response assessment was done monthly for the metronomic arm for the first 4 months, and then it was done once every 2 months. Whereas for the cisplatin arm, it was once every 3 weekly for each of the chemotherapy cycles, and then it was once every 2 months. Next slide. The primary outcome here, it was bold, it was overall survival, but the secondary endpoints were PFS, proportion of patients who responded, toxicity, and quality of life. Next. So the baseline characteristics of patients in both the arms were quite balanced. There was no obvious difference as such. Most of the patients were tobacco chewers, and the oral cavity subsite was the maximum, including the tongue and the buccal mucosa. So there is nothing like skewed in the distribution of the patients who were included in the study. Next slide. So if you look at the results, the median cycles, both the arms, they received a median of 2 cycles only, and the follow-up duration was around 15 months. The 6-month OS was 62 versus 50%, which is a difference of 11.3%, and the p-value for non-inferiority was less than 0.001. So it was highly significant. The median overall survival was 7.5 months versus 6.1 months. The median 6-month PFS was 26 versus 8.36. So you can see that there is a clear separation of the curves, and it is the tail of the curve again comes together, but still for a very long time, almost 15 months, you can see that there is a clear separation of the curves. And this is the overall survival curve. Next slide. So the treatment benefit was seen across all the subgroups, whether it be age more than 65 years, whether it be oral cavity cancer, whether the patients who were treated previously or not. Definitely patients who were treatment naive in the first line setting, they did better. And patients who had a treatment free interval of more than 6 months also did better. Next slide. The adverse events, this was one of the important things, because the grade 3 and above adverse events that were seen with the metronomic arm were only to the tune of 19%, and that also you can see it is 13% is hyponatremia. So I think in our common practice we don't see such adverse events very commonly. So it's overall a very well tolerated arm as compared to the cisplatin arm, where we know that we can get nephrotoxicity, neurotoxicity, electrolyte imbalances. All these things are very common with cisplatin. So the grade 3 adverse events were almost to the tune of 61%. So there was a huge difference between the two arms in terms of adverse events. Next slide. Also, we can see that the quality of life indices, they did a global health quality of life index, and it was clearly evident that the metronomic arm people had a statistically and clinically significant higher global health status quality of life score. There was no difference in the functional score and the symptom scores, but I think the global health quality of life score speaks for itself. That means that these patients enjoyed a better life than the cisplatin arm people. Next slide. So the discussion is, this was the first randomized phase 3 trial in head and neck cancer. Use was associated with a 22% decrease in the risk of death and a 50% reduction in the risk of disease progression. This is actually a very good endpoint for most of our patients. Also, this regime was associated with a significantly higher global health status quality of life score and a clinically meaningful improvement in quality of life. They included platinum refractory disease, that is patients who had progressed 3 to 6 months of the last administration. They did not include patients who had progressed less than 3 months of the last platinum regimen, but 3 to 6 months again is a fair weight. Next slide. Most of these patients had oral cavity cancer. We know that all these Western studies, they will have more patients who have got non-oral cavity subsets. But here, 77% of the patients had oral cavity cancer. Most of these patients had advanced disease. So this is more representative of the population in our country. And definitely the results would be more what we are expecting in our practical day-to-day practice. Less than 20% of these patients developed grade 3 or higher adverse events. Whereas in the other immunotherapy trials, you know that even in monotherapy with pembrolizumab, you get an adverse event profile which is more than 50%. So definitely adverse events are there. They will not only, they are undesirable, but they will also add to additional financial burden to the patient. And it's an oral treatment at home. The patient has got fewer visits to the hospital. So it definitely helps the patient. It's definitely more convenient to the patient. Next slide. The limitations were the median overall survival. As she said, Dr. Shruti said that median overall survival of 7.5 months is obviously less than all the immunotherapy trials. If you go for the sequential, whether TP Extreme followed by Keynote. So definitely these regimes are the treatment of choice. They're the standard of care. This regimen is more for the patients who cannot afford these regimens and should be used only if the cost is not possible, or they are like the performance is not that great. Probably in this trial they use the PS0 and PS1, but probably toxicity is a major concern for the patient. Definitely we can ensure a good quality of life with the metronomic therapy. Some can argue that the control group was only a single agent. Why did not they use a doublet or even a triplet? But there is no evidence to suggest that a doublet or triplet improves the overall survival. But we know that it increases the incidence of adverse events. The optimal metronomic dose actually might be even lower than this. It might be even 9 mg per meter square. We don't know. Probably in future trials will address this question. And there might be a difficulty in patients who have difficulty in swallowing. And this was a single center study. So overall, this was a very good study, well planned. It had a good endpoint of overall survival, and definitely the impact we can see now in our day-to-day practice. Patients, most of the patients, as definitely if somebody in my practice who comes for immunotherapy or even for cetuximab, definitely I would recommend them. But most of the patients cannot afford them, and for those patients, whether to give chemotherapy or metronomic therapy, definitely this trial should answer most of our questions. Next slide. So thank you indeed. It was a very good discussion so far, and definitely, Dr. Shruti, I would not like to debate with you that whether immunotherapy is better than metronomic. It is better, but for definitely most of the patients that we see in our day-to-day practice, metronomic therapy definitely has a very big role to play, and we have to go for further combinations of metronomic with chemotherapy or with immunotherapy. Probably that will also help us in the long run. Thank you.
Thank you, Pinaki. I think you rightly said there is no much debate because the data in favor of immunotherapy. But there is a one or two points which is very important here because our class of the patients are different. And I think those patients who is not affordable, definitely we can try immunotherapy, metronomic chemotherapy. One of the important concern is now there is a very upcoming data of combination of metronomic chemotherapy. Like we have a data of the single agent methotrexate. And we also know those patients who received cisplatin upfront. I think there is no point of comparison cisplatin versus methotrexate in the subsequent line because nobody used platinum after the patient who progressed in the platinum. So I think there are the data which are coming. I think TMH is doing the study of the 3-drug metronomic chemotherapy of TKIs with methotrexate and celecoxib. I think the data is quite impressive. And one of the best part is these are the oral treatment. I think that's a way we can manage the patient. And some of the patients, they are presenting very bad disease like a fungating mass, discharge, bleeding. I think with giving the methotrexate, the way the patient responded, I think even we are looking for this category of the patient, I think we should be very much selective in prescribing our drug, especially in the patient, their response actually a very aggressive response at the beginning. I think those kind of the patient, we can still try a methotrexate. And the second thing regarding the limitation of immunotherapy in high tumor burden. So we all know 30% patients are actually hyperprogressive. So I think with those kind of the patient quite symptomatic, I think we have to still look for the chemotherapy option, though there is no head-to-head comparison of combination of the 2 or 3 metronomic chemotherapy together with immunotherapy. But I think in future will come more and more data. With this, I thanks to both the speaker for the nice discussion. And I think we are all waiting for the panel discussion. And I invite Dr. Govind Babu sir for moderation of this interesting panel. And sir, I can read the name of the panelists: Dr. Rahul Jaiswal, Dr. Amit Jetani, Dr. Kaushal Patel, Dr. Gopal Sharma, Dr. Pinaki Moto, and I think Dr. Beva and Dr. Priyanka is not there. 5 or 6 panelists as of now. Over to you, sir.
Yeah, thank you, Ashish. I've been listening to what's been happening since 6 o'clock. I think it's been wonderful discussions. If compared to all of you, I'm from the oncologist, and I'm very happy that the reins of medical oncology is in very good hands for the future. So congrats all of you. So with that, let me start off. So we're going to do a panel discussion on head and neck squamous cell carcinomas. I have 2 cases. One is locally advanced and one is metastatic. And I think the data which I'm going to show has already been discussed at length. So I will just put everything into perspective. So greetings from Bangalore. I'm sure you can festivals that we celebrate, and the other one is a very
Sir, your voice is little bit
the harvest of groundnuts, and this is the giant bull in Bangalore. So I think yeah, can you hear me now?
Yeah, now it is better. Can you switch off your video?
Hello.
Sir.
So are all the okay? Yeah, that's what I'm going to do now. So are all the panelists there?
I think Dr. Rahul, Dr. Amit, Dr. Kaushal, and I think Dr. Gopal and Dr. Pinaki, 5 panelists are, I think, in the board. As of now. Yeah, we are not able to hear you right now. Sir, you have to unmute. I think you are on mute modes. Yeah.
Okay. You can hear me now, I think, no? Okay.
Yeah, now it is better.
So again, I think you are seeing the case that I've shown. She was being investigated for pain in the throat for 3 months and a neck swelling.
Sir, I'm not getting your screen. We're not getting.
Now?
No, sir.
No?
No, sir.
Okay.
Ravindra, you have the backup?
No, 1 minute. The screen sharing
You have
was
stopped
not.
the screen share. Yeah, you have to
Yeah.
do it again.
Yeah,
sir.
yeah. Yeah.
Yeah, sir.
Yes, sir.
Okay.
Please.
Okay. So you have the patient details here. Clinical evaluation showed that she had performance status of 1. She had bilaterally palpable level 2 lymph nodes in the neck, right more than the left, growth in the right tonsil, right base of tongue and vallecula. And the biopsy showed that it was a moderately differentiated invasive squamous cell carcinoma. So this question is to Dr. Rahul. Are you there? Would you
Yes,
look
sir.
for any biomarkers in this patient?
Biomarkers in first line, sir.
Yes.
This is this PD-L1, MSI, or all these things.
Okay.
That I
So
will
one of
not.
the old
In
one of the
upfront,
old things.
HPV is okay.
Yeah, that is one of the biomarkers that has been considered. So I just thought I'll touch on that.
So if
So
I do a HPV,
what we
then
do is, yeah.
HPV, I think yes, many of the centers do HPV. There is a debate whether we should do or not because
Yeah.
we are not able to differentiate treatment on basis of HPV. Only thing is that we know that it is a more chemosensitive and radiosensitive disease. So there were also some studies like, or what happens sometimes my radio colleague that it is HPV positive, it is radiosensitive. They try to reduce the dose of the radiation. I have seen some patients, or if their toxicity occurs, then they reduce the dose of radiation. But on the contrary, it is a very good sensitive disease. We should not decrease treatment in such patients, HPV. So for me, practically HPV changing the treatment, I don't rely too much on that.
Yeah. So this is some data for you that in the Western, the HPV report is almost 68%, but most Indian studies show a lesser percentage. And one of the things that has been told is that, like you said, de-escalation in HPV positive, it has not really become the standard of care today.
We should not. I
in the
personally
Indian
believe
context.
that we should not do it.
Correct. As of now, none of the guidelines really recommend that. It is still a debate. So, in fact, this positivity or negativity is people believe is irrelevant in most of our Indian population because the tobacco chewing habits actually override the positivity or negativity of HPV.
On the contrary, sometimes it happens that treating doctor feels that it is a chemosensitive, radiosensitive disease. So in the last week, generally what happens in the 5th and 6th week of radiation, there is too much of toxicity. Then they think that it is the HPV associated disease. It's a good prognosis. We de-escalate the treatment. We reduce.
I agree with you.
Skip the last week, then that may be detrimental for the patient.
Correct. They should not do that. I think that is the other important thing that we need to do is have an MDT. You don't unilaterally take decisions. Yeah, I totally agree with you. So this is just to show you, this is from the RTOG phase 3 study, which looked at HPV positivity and negativity and showed that the overall survival was better in the HPV positive, quite a bit of difference. But again, I must remind you that this is not Indian population.
Yes,
so there are several methods of HPV testing. I don't think we need to really go through that. So one of the important things is who should be tested for HPV. Dr. Amit, and as you already heard that, do you test it in?
Those with oropharyngeal cancer, we recommend HPV testing just for prognostication.
Yeah. So this is what is the recommendation. Like you said, it is oral cavity, non-tobacco use, T stage with advanced end stage, and high-risk sexual behavior. These are some of the parameters that you would look into when you ask for a very relevant as of today. So back to our patient. This is the MRI scan, and as you can see that there's a large lesion and extensive bilateral neck nodes, almost 20 millimeters on the right side. There is a staging difference when you look at HPV positivity and negativity. Probably that's the only thing that you will look for HPV testing. But again, how relevant this is in the Indian context is debatable. This is from the AJCC 2017, and they have staged looking at whether they were HPV positive or negative. And if I put all the parameters of this patient into this, and if this patient is HPV positive, she would be stage 2. But if she is negative, then it becomes stage 4A. Again, as we have already discussed, in the Indian context, this may not be very relevant. So how do you treat this patient, Dr. Kaushal?
Yeah, hi, good evening, sir. This is
Good
a
evening.
basically advanced malignancy. We can say advanced
Correct.
head and neck malignancy, whether it is HPV positive or negative, we can consider it in a palliative setting. So as earlier we discussed, I would like to add something in biomarkers. I would like to go with EGFR amplifications, tumor mutation burden, PDL1 and CPS. If the CPS score is more than 20, then I would like to consider with immune plus chemotherapy combination in this patient. Even though the 48 shows only immune therapy, they can work.
1 minute, Kaushal. Before we go to that, why did you ask for EGFR amplification? And do we have any evidence for that?
Yes, sir. That is two different things: EGFR mutation and EGFR amplification.
Yeah.
The mutation all we do in lung malignancy.
No, we are talking of head and neck today.
Yeah, so EGFR amplification in head and neck malignancy have some of the importance aspect in treatment choice. If the patient is EGFR amplification positive, then the cetuximab or EGFR inhibitors having a very good response as per foundation medications data. So I would like to do EGFR amplification along with PDL1 and CPS score in these particular patients. Or
so
even
I would really not go by what you said, because we have done enough studies and looked at EGFR amplification. Of course, it's positive in almost 85 to 90%, 100% of head and neck cancers. And we have done exploratory analysis and shown that there is no correlation. So none of the guidelines actually use this as a biomarker. So I would like to differ on that. Yeah, you can go ahead with other markers.
Yeah, fine. So in this particular, if the patient's PDL1 or CPS score is more than 20, then I would go with the immune therapy combinations. And if the patient's score is less, then I would like to go with the cetuximab-based treatments.
Okay, just to make things easier for you, I put the choices. So you can take your pick from all this. What would your first choice be?
Sir, if we are going in the curative intent right now, then I would like to go with the radiation therapy plus weekly cisplatin plus nimotuzumab as a treatment choice.
Yeah. So I mean,
why not downstage the trial, the downsaging the disease with the TPF?
Yeah, this is looking locally advanced. So neoadjuvant chemo and then RT cisplatin
trial of 2 cycle of DCF and then either response. If it is a very good response, then you can go for it. Trial of this curative TTRT after downsaging the disease.
Yeah. So I mean, this may not be the right platform for debating. I am against the use of palliative therapy. When we say palliative therapy, it's sort of very discouraging for everybody. None of the other specialties use this term palliation. Be it diabetes, renal failure, or hypertension, they treat lifelong, but they don't call it palliative treatment. So I think as oncologists, we must slowly move away from using this. This is my personal opinion. So yeah, so these are the options that you have. And the evidence is some of this looking at concomitant chemoradiation versus radiation. And this is data from 2010. Actually, this is an Indian paper. But what this patient got was radiotherapy. And as I think Kaushal mentioned he would have given cisplat with radiation and nimotuzumab. That's what this patient got. And if you're using a chemotherapy schedule, what would you use? What are the schedules that you generally use? Dr. Vaiba, do you use a 3-weekly schedule or a weekly schedule?
The Baba is not joined, I think.
Oh, Vaiba is not there. Okay, then Dr. Kaushal, you can take this. So we're talking about 3-weekly and weekly. Okay.
If we are using nimotuzumab, then weekly cisplatin, and otherwise 3-weekly cisplatin is category 1. But in our routine practice, we use is weekly only.
Yeah. So we have two papers, one from my institute.
Total dose of cisplatin should be 200 mg per meter square. So
That's right.
Yeah. So if using weekly, then it should be more than 200 mg per meter square.
Yeah. So we have two papers comparing weekly versus 3-weekly. This one is from Tata, and this is our own from our institute. And both showed that the responses are very, very similar, and the toxicity is also very, very similar. But I personally am comfortable with giving weekly cisplatinum, because I believe then I'm looking at my patient every week and I can manage the toxicities better. So this is looking at evidence.
The problem with 3-weekly regimen is the dose of cisplatin 100 mg per meter square will be very high. So one day you have to admit the patient, you have to pre-hydrate the patient. Second day you have to
of course that goes without saying. So, yeah, definitely.
So it's a cumbersome to get an admission for 3 to 4 days. And, so most of us, I think most of us, we are happy with weekly, and initially we used to give 30 mg per meter square, but now we give 40 mg per meter square.
Correct. We are now using 40 mg, and weekly is much more comfortable for patients as well.
We try to target to 200 mg per meter square.
Correct. So what is the evidence that we have for HPV negative patients? Then this is actually from different studies of nimotuzumab in our country. One of the first studies is the BEST trial, which was done several years ago, for which I was a part. And then now we have the data from Tata Memorial Hospital, and all of them showing you that there is definite overall survival benefit. In fact, for the first paper now, we have almost 7 years follow-up, again showing you that the benefit continues even at 7 years. This is a recent paper from Tata Hospital, and this is looking at, again, nimotuzumab. Again, the follow-up for this is not very long. So this is, again, they looked at the HPV negative oropharyngeal cancers especially, and in terms of median PFS, local control, and overall survival, the nimotuzumab arm is doing better. So people do believe that this is a different molecule as compared to the other EGFR targeted agents. And Dr. Gopal, are you there? Dr. Gopal Sharma?
Yes, sir.
Okay. I'm sure you have used nimotuzumab in the past and the other EGFR blockers as well. Do you believe that this is a molecule that can be differentiated from the others?
Maybe, sir. We have used nimotuzumab since many years.
Correct.
But still, in head and neck cancer, there are not much trial other than Tata. The international guidelines, international trials are lacking. So,
I'm sure you'll understand that you'll never have international trials on this molecule because this is a molecule out of Cuba and now out of India. Since Cuba had an embargo from US, this molecule never came up.
But now we are using with cisplatin with weekly regime, and response rate are better, and toxicity profile is almost similar to single agent cisplatin. So toxicity profile is not a concern.
So this is a slide I just put in to compare the other targeted agents. And if you see skin rash, almost single digit with nimotuzumab, whereas with others, you do have significant skin rashes. And more important is hypomagnesemia, which is always seen with cisplatinum that we use. Hypokalemia, associated hypomagnesemia is an important part, which we normally don't recognize. and hypomagnesemia can lead to a very significant hypokalemia as well, and that can produce mortality in our patients. So this is a side effect that is not seen with nimetuzumab, but seen with both cetuximab and panitumumab. So I think this is an important differentiating factor for nimetuzumab. So Dr. Rakesh, are you there?
No, sir, Rakesh is not there.
Okay, so this is again the role of other anti-EGFR. We do have the other cetuximab, panitumumab, and afatinib. And there is some data, and cetuximab you already heard at length. Panitumumab has similar activity, and they believe that it is safer, but it's not really taken off at all. So would we consider other options for this patient? So chemoradiation versus radiation. And today, I think nobody debates about chemoradiation being the standard of care, whether you add a targeted agent or not. I'm sure none of us are using radiation as a single modality, especially with the evidence that is there today and the good way that most of us are able to handle chemotherapy. So this is cetuximab, again showing you that there is benefit of adding cetuximab to radiation. But as compared to nimetuzumab, you cannot combine cetuximab plus cisplatinum with radiotherapy because of the toxicity. So this is again the data from that particular study. And this is a meta-analysis showing you that concomitant chemoradiotherapy with cetuximab is not recommended because of the toxicity profile. And this is just published in September 2020. So the combination of cisplatinum, cetuximab with radiation is not to be taken forward. So with that, let's go on to checkpoint inhibitors. And Dr. Shruti actually debated on this, but Dr. Pinaki spoke about Metronomic. So let's ask Dr. Pinaki about checkpoint inhibitors.
So definitely, sir, checkpoint inhibitors in this patient where we are looking at a curative, definitely in the first line, I would not, but in the second line and in the first line, metastatic unresectable, definitely checkline has got a role. We have discussed all those trials at length.
Exactly. So I've just put up this slide. As of today, none of these checkpoint inhibitors are approved in first line, locally advanced. They're all in metastatic in first line and second line.
Sir, can I put one point here?
Yeah, go ahead.
So this patient is a loco-regionally advanced oropharynx. So why not the induction chemotherapy? We have a very good data of TP extreme followed by the local radiation because most of the patients come with the local issue. So would be an option, I think, that can be.
Of course, that's a good option. In fact, I'm very fond of using nimetuzumab with induction chemotherapy, and we have had excellent responses. So many of these bulky tumors, I do use induction chemotherapy with a targeted agent and then give them chemoradiotherapy.
Absolutely.
That's, I think that is what most of us are doing, and I think it's a good option. Right. So Dr. Priyanka Das, are you there?
I think she's...
No, I think. Okay. So biomarkers again. For immunotherapy, these are all that we look at. And I think Dr. Shriti already showed you this particular slide. It's important that we remember about the TILs. And this is one slide to just look at these biomarkers, the PD-L1, CPS, genome profiling, and TMB. So many of these studies have used these markers differently, and each of them are not exclusive. Many of them are useful in some, but not useful in the others. So with the immune checkpoint inhibitors, we are still at a loss to have an ideal biomarker, but by far PD-L1 seems to be the best, and TMB is emerging. So this again is just to show you that we have cold tumors and hot tumors, as Dr. Shruti said, and hot tumors are the ones that are going to benefit with chemotherapy, with immunotherapy, and we are looking at different ways to try and see how we can make them hot. So this is just to show you that the immunogenic tumor microenvironment is important, and if a tumor is not immunogenic, then what we do is give chemotherapy or radiotherapy and make them hot tumors so that your immunotherapy can bring out the best in them. So I think this we've already discussed. This is in the recurrent setting, actually. I'll come to that later. So this is one of the phase 2 trials of pembrolizumab in locally advanced. So although it is not yet approved, I thought I'll just share this data with you that this trial is ongoing. And this is in about initial 25 patients who are enrolled. And the conclusion from the study was that there were no safety issues. There were no delays in curative intent. So they're using this as an induction therapy or neoadjuvant therapy. Again, but limited by the number of patients. But probably this is going to be the way forward in the use of immunotherapy much earlier on in the lines of therapy. And this is looking at combining chemoradiotherapy with pembrolizumab, and this is the schema of the study. And as you see, this is just a phase 1 study with 27 patients, and this shows you how this study is designed. The primary endpoint is looking at complete responses and safety, and secondary endpoint of PFS and OS. So what is the data at 150-day follow-up? You can see that the complete response is 78%, and the stable disease is not there in anybody, partial response is there, and only one patient had progressive disease and one death. So again, seems that combining chemoradiotherapy plus pembrolizumab is very exciting, and with such excellent responses, I'm sure this will be coming in very, very rapidly. So Dr. Rahul, although we don't have any approvals right now for this, have any of you used this? I have not used in this setting, in the first line.
No, sir.
Okay. Just a word about adjuvant therapy. As of today, chemoradiotherapy is the standard of care, and there is a study going out of Singapore on there's a phase 3 study looking at nimetuzumab, and they are set to enroll 710 patients. Almost 75% enrollment is done, but we need to wait for a longer follow-up. Their endpoint is disease-free survival at 5 years and also overall survival. So this is one of the adjuvant trials that is ongoing. The other one is with atezolizumab, which is an anti-PD-L1 antibody, and this study is called VOX. And I happen to be the data monitoring committee chair for the study. And if you see the person in the middle, he is Dr. Everett Vaux. He's an authority on head and neck cancers from Chicago, and he's just been elected to the ASCO as a president. So this study has 406 patients, and the recruitment is over. We'll have to wait because this is an adjuvant setting, and the outcomes will take quite some time to come. So these are two important studies that one should wait for to use these targeted agents and immunotherapy in adjuvant setting. So back to our patient. She completed her treatment in July 2017, and she was in CR after treatment. And the last follow-up in October 2020 is that she continues to be in complete remission. So with that, let's go on to the metastatic patient. I have one patient for that. This is a 40-year-old man, smoker, less than 10 cigarettes a month, PS1. He has a wide lesion in the right tonsil and cervical mass on the right lateral aspect. Fiber optic examination shows presence of a wide exophytic mass arising from the right tonsil and infiltrating the ipsilateral tonsillar pillar. Biopsy shows that it is a poorly differentiated squamous cell carcinoma of the right tonsil, and CT scan shows that there is a 5 centimeter mass in its largest diameter, and it involves the base of tongue and floor of mouth. A single 2.5 centimeters lymph node metastasis in the laterocervical chain. Multiple bilateral lung lesions were detected. So this was actually picked up by a PET scan because of the avidity that was there. So now we are dealing with the metastatic disease, and this is the staging 4C according to AJCC. So we will not discuss the biomarkers here. This is the CT scan of the local area and the chest. You can see the metastatic nodules there. So Dr. Rahul, how would you treat this patient? So we are dealing with a metastatic head and neck squamous cell carcinoma.
Okay. So it's a metastatic head and neck carcinoma. Now, question is whether when to use cetuximab and when to use this immunotherapy, pembrolizumab.
Yeah.
So the thing is that both are the costly medications. First, if we on this platform, obviously cost is not an issue. We have to see the evidence-based medicine. So what we have concluded in today's talk that if we use cetuximab first, then we have a place for immunotherapy in a second line setting.
Correct.
If we go by this sequence, first line, if cost is not an issue, then in a metastatic or a recurrent head and neck cancer, uh, my choice would be cetuximab combination with a chemotherapy in a first line, then immunotherapy in a second line, and third line will be a methotrexate jactinib combination.
Right. So that's a sequence.
What I concluded from today's talk and from the various recent studies.
Correct. Correct. So this is the extreme study for you, and you also heard the TP extreme. So that is the advantage of extreme and TP extreme. Dr. Bharat nicely showed you that. There is some data to combine chemotherapy plus bevacizumab also, although this is not taken off very well. There is some advantage of using bevacizumab, and it's shown overall survival advantage as well. So maybe this is an option that we have because we have so many biosimilar bevacizumab in our country, which is definitely affordable. Again, back to the earlier slide I showed you that the role of immuno-oncology and nivolumab, pembrolizumab are approved in the second line and metastatic disease. So you already saw the data from Checkmate 142, and this is showing you the overall survival advantage. This is in the first line setting, nivolumab versus investigator's choice. You can see the 12-month overall survival of almost 40% versus 15%. And this is based on the prior cetuximab therapy. So they believe that, again, as Dr. Bharat told you, that cetuximab probably is sensitizing these tumors to the immunotherapy activity. So it seems that it's slightly better if they have received cetuximab earlier on. This is pembrolizumab keynote 40. Again, this slide was shown to you is beneficial. This is keynote 48 again. This was discussed to some extent. This has 3 arms: pembrolizumab monotherapy, pembrolizumab plus chemotherapy, and the third arm is the extreme arm. And as you can see that CPS more than 20, pembrolizumab has an overall survival advantage as compared to extreme. In CPS more than 1, again, there is some overall advantage, but not as much as if it was more than 20. So this is pembrolizumab plus chemotherapy as compared to extreme. Again, you can see that there is an advantage. So Dr. Amit, are you there? Amit is not there. Ashish, would you take this question?
Yeah, Amit is
experience with checkpoint.
unmute.
Oh, Amit is there? Okay. Amit, what has been your experience with checkpoint inhibitors in this setting?
In first line, I haven't used P plus F with pembrolizumab, but after progression on the platinum containing chemotherapy, we have patients on nivolumab, and 2 patients are in complete remission, actually since 2 years.
Okay. And how long have you used it?
Sorry, sir?
How long have you been using this for this patient?
For 2 years only. For 2 years
it's only. Continuous. It is a continuous thing that you're using. So when do you plan to stop?
I'm planning to stop at 2 years only.
Okay. Okay.
2 years.
Okay. So what are the newer agents that we are looking at, Dr. Kaushal? We have seen so much of data with checkpoint inhibitors. Do you believe there are some other newer agents that we can look at, and how would they help us? Other than Metronomic, of course.
Sir, hope for some of the new checkpoint inhibitors data, promising data in advanced head and neck malignancy, apart from the nivolumab and pembrolizumab. Apart from that, her TKI like afatinib has also shown some of the advantage.
Correct.
Apart from that, we are looking from some of the data which combining cetuximab plus immunotherapy in future.
Correct.
So these are some of the comments for future updates in head and neck malignancy.
So one of the interesting molecules I came across was this indolamine inhibit dioxygenase inhibitor called ipacadostat. And again, this is very early data. It's said to inhibit T cell proliferation and induce T cell apoptosis. And this initial data with combination seems really exciting. They had an overall response rate of 39% and a disease control rate of 65%. So this is one pathway which till now was not targeted, and probably this is one of the first drugs that has come in this range to target this pathway. So this is one new drug that I came across. Again, as you heard from Dr. Shruti, there are several combinations with immunotherapy agents that are ongoing. IDO inhibitor I showed you just now. There is another KIR antibody in combination with nivolumab and lenvatinib with pembrolizumab that is being taken forward, and HDAC inhibitor orinostat with pembrolizumab. So these are all phase 1-2 studies, and initial responses, as you can see, are pretty encouraging. The largest study is called the EAGLE, which used durvalumab plus tremelimumab, and unfortunately, there was no overall survival benefit from this study. There are other combinations, as you can see, some of the newer molecules which still have just a number but no name. These are all very early stages of development, and initial data seems encouraging. But as we all know, phase 1, phase 2 data may not really hold on in phase 3. So we need to wait for mature data from these new molecules. So Dr. Vaibhav, are you there?
No, sir.
Okay. Dr. Ashish, maybe I'll have to pull you in for this.
Sure.
Could we have any other considerations or options for this patient? So platinum based plus cetuximab, I think we have discussed already. So how has been your experience of platinum plus cetuximab?
So no, sir, I'm not very keen. Only thing in first line where we are using as a TP extreme data. So chemotherapy.
Okay.
So I'm very fond of using this combination because, avoiding the 5-FU, which are toxic regimen 3 to 4 days.
Correct. I agree with you. I agree with you.
So I've changed my practice. I'm using TP extreme followed by immunotherapy in the second line.
Okay.
Cancer. And the challenges in head and cancer is to performing the CPS scoring because these are the patients who are quite symptomatic.
Correct.
We can wait for the report of 10 or 15 days to get the results. So we need to start.
True.
Early.
Yeah.
So,
I think that way TP extreme is really good because you don't have to wait for any biomarkers. You can immediately start, and you do see responses very rapidly.
And the second thing,
and of course, I have a bias towards.
Yeah.
Go ahead.
The second thing.
Go ahead, Ashish.
Second thing which I am very fond because I have used a nivolumab in the patient who recurrent and metastatic post platinum. I think more than 50 patients we have, and I think it's an impressive response for those patients who completed at least for 4 or 6 doses.
Correct.
Those patients having a CR/PR, I think, or stable disease, they responded very well. But it's, as in my experience, those patients who completed at least 4 doses, the clinical benefit rate is over 60%. So the only problem with those patients who is a hyperprogressor. So I think those patients being high tumor burden, I'm also looking into combining some chemotherapy drug with the Novolumen at beginning, so that we can control that hyperprogression. So I think
I totally agree with you on that. Checkpoint inhibitors do take at least 4 to 6 cycles before you see an appreciable response, and since it is not rapid, I totally agree that adding some sort of chemotherapy along with them will definitely be beneficial. So this is a paper from, again, our own country. Dr. Dole is the first author on this. This is about nimotuzumab in recurrent metastatic squamous cell carcinomas. And again, they've compared the various studies looking at different monoclonal antibodies, and they've shown that, in fact, nimotuzumab with chemotherapy seems to have response rates that are very similar to either Extrema or Spectrum trials. So this is a viable option for our country because of the affordability as well. And there is emerging data coming out about nimotuzumab that it does have a significant immune regulatory mechanism as well. So that is being explored now. So we were talking about induction regime followed by chemoradiation in metastatic disease. So Dr. Gopal, what is your comment on this?
Sir, in metastatic setting, generally, I agree with Dr. Ashish. The primary aim is chemotherapy who give faster response. So, docetaxel cisplatin with cetuximab as a first line if patient is young and performance status is good. And if patient is older, then we can wait for CPS scoring, and if more than 20, then we can use as a single agent pembrolizumab if the morbidity is high. And
so
otherwise,
Gopal, you said if the patient is old, you will wait, but he may not have too much time to live.
If tumor burden is not much,
correct.
and if patient is older and there is And sir, my personal experience with nivolumab as a second line agent is just like Dr. Ashish. And one or two patients have very good response post multiple line of chemotherapy, and then on nivolumab, all complete remission more than a year. So nivolumab is doing good as a second line agent. So I think we should keep IO as a second line, and if patient is young and good performance status, then docetaxel plus cetuximab as a first line agent.
Yeah, I think that is a great sequencing, because even if the tumors are cold to start with these chemotherapy, we are actually converting them into immunogenic tumors. And I think that is the basis why all of you are getting excellent responses in second line. So I think that's an important thing. So I think it will be worthwhile if all of you can collect your data and actually publish it, real world data, it will be very interesting.
Right, sir, right.
Ashish, maybe you should take the lead.
Sir, we have already submitted our data, and I think the data, this Tata guys and Jyoti is going to publish the data. The data
yes. We have also sent our data to that. Yeah, that's right. Okay, that's nice. So metronomic chemotherapy, I think, was already discussed, but for completion's sake, I've just put it here. So this is the basis why metronomic chemotherapy is being used, and because it seems to have effect on the immune system, as we have already discussed. And I think Dr. Shruti had put up a slide that metronomic chemotherapy is poor man's immunotherapy. I think it's very true. So I think we were talking about what are the drugs that we will use. In fact, even at Kidwai, we've been using metronomic chemotherapy for quite some time, and we've just collected data about 100 patients of head and neck and cervix as well. So the combination that we've been using is cyclophosphamide 50 milligrams BD for 2 weeks, methotrexate 15 mg weekly, and celecoxib. So I think it's a good thing especially for our Indian patients. And this is a paper from Banavali actually. So this is the difference between conventional chemotherapy and metronomic chemotherapy. And this is the paper from Tata Hospital. This is using erlotinib along with the metronomic chemotherapy, a triple metronomic chemotherapy. So this is actually paper from AIMS, and this is specifically for head and neck cancers, especially in the 2019 pandemic. So this seems that it's an important thing, especially when patients were having problems reaching hospital, getting intravenous drugs, that metronomic chemotherapy was an important thing. And this was from the AIMS hospital. So how did we treat our patient? We chose to employ induction chemotherapy followed by chemoradiotherapy. She received 3 cycles of cisplatin docetaxel as induction and the standard dose with grade 2 and grade 3 toxicities. And this is the first restaging in September 2018. You can see that the oropharynx disease is there, but the chest nodules have completely disappeared. This is not the usual responses that we see in metastatic head and neck cancers. We were lucky that with this induction chemotherapy, they disappeared. This was the second staging in February 2019. Again, he continues to be in complete response. So follow-up, this patient, the last follow-up has been in June 2020, and he continues to be in recurrence-free state. So this is the Indian Journal of Cancer, which has actually brought out the Indian clinical practice consensus guidelines for head and neck cancers. I'm one of the authors on this, and if you really want to know about each subsite, this complete issue covers every subsite of the head and neck cancers. So I would urge you to go through this. So with that, I think I will stop and thank you all. If there are any specific points that each one of the panelists would want to make, this is the right time.
Yeah, thank you, sir. Such an excellent moderation. Any comments, any of the panelists?
No, thank you, sir. Thank you, sir. Nice moderation, sir.
Thank you so much. All the data was already discussed, so it was just for me to put in the context. That's all.
Thank you, sir. Thank you. Good night.
Like I said, I'm so happy for all of you. I think medical oncology is in very safe hands in India with all of you. Thank you.
Thanks for your support, sir. And I think since last 2.5 hours, we are discussing with head and neck session on the Sunday evening. Thanks to all the faculty and the delegates for their active participation. And as I said, thanks to all and goodbye to everyone.
Thanks, Ashish. Good night.
Bye.
Thank you. Thank you, Ashish bhai.
Bye-bye. Thank you.